Imaging of Mediastinum, presented by me, Dr. Rashan Nadim Ahmed, radiologist at Department of Surgery, College of Nineveh University. Mediastinum is a space in the thorax that lies in the midline of the chest between the pleural surfaces of each lung and extend from the sternum to the vertebral column. The mediastinum is divided anatomically into superior mediastinum, middle mediastinum, anterior mediastinum, and posterior mediastinum, as we can see in this figure. However, radiologically, the mediastinum is divided anterior, middle, and posterior by these two imaginary lines. The first line, which is in red, is the line anterior to the trachea and posterior to the inferior vena cava. This will differentiate between anterior and middle mediastinum. The blue line is an imaginary line passing 1 centimeter posterior to the anterior border of the vertebral body. This division allows us to make a more narrow differential diagnosis. Wide mediastinum. This is an example of 30-year-old man in motor vehicle accident having wide mediastinum. When you have a wide mediastinum, ask yourself, is it a technical problem, like in rotation, for example, in AP film, lordotic view, supine position, inadequate inspiration? If so, repeat the film before proceeding to CT scan. Then ask, is it new? Is it something new? Or the old films all showing the widening of the mediastinum? This is in chest X-ray in AP supine position, and this is in the AP upright position. Here the lungs become more clear, and the mediastinums, especially the superior mediastinums, looks a bit narrower. And this is the AP upright position of the chest X-ray. Show the difference that we can obtain by changing just the position of the patient and the technique of taking chest X-ray. The goals. Whenever you see a mass on a chest X-ray that is possibly located within the mediastinum, your goal is to determine the following. First, is it a mediastinal mass? Because many masses may be, for example, in the lung or in the chest wall and looks to be in the mediastinum. We should be sure that the mass is in the mediastinum before going to think in the differential diagnosis. Second, we want to locate the mediastinal mass to certain part, whether it's anterior, middle, or posterior, and again to decrease the differential diagnosis list. And third, are you able to characterize the lesion by determining whether it has any fatty fluid or vascular component? This is especially in the CT scan, because in the chest X-ray we cannot differentiate between the soft tissue and fluid and so on. لكن أحيانا في chest X-ray ممكن مثلا we can look for certain signs, مثلا deviation of trachea. مثلا mediastinal mass which cause deviation of trachea usually seen in retrosternal goiter. First, is it a mediastinal lesion? الحقيقة عندنا عدد من الفيتشرز اللي تحدد لنا أنه الماس is mediastinum. الماس shouldn't contain aerobronchogram. الإيروبرونكوغرام وهي radiological sign تكلمنا عليها بالعملي وفي المحاضرات السابقة، هي عبارة عن translucency caused by the air which is present in the bronchi في مكان بها opacity نتيجة air space filling أو alveolar filling with fluid، مثلا بالconsolidation، يعني منطقة بها consolidation شوف بها aerobronchogram. فإذا كان عندنا ليجن بينه aerobronchogram فهذا يدل على أن الليجنز مو mediastinal. الليجنز is intraparenchymal inside the lung. Second, the margin. The margins with the lung will be obtuse. And third is the mediastinal lines. عندنا certain lines in the chest X-ray like the zygosophageal recess and posterior junction line and so on. Those all will be disrupted by mediastinal line if present in these regions. There can be associated with the spinal, costal or sternal abnormality. يعني ممكن نكون شاكين posterior mediastinal mass ونلاحظ أنه أكو widening بالintervertebral disc space أو أكو destruction للvertebra. This is a sure sign that this lesion is in the posterior mediastinum. A lung mass abuts the mediastinal surface and creates acute angle with the lung, while mediastinal mass will sit under the surface creating obtuse angle with the. لاحظ بهذه الصورة الفرق بين parenchymal mass والميدياستاينال mass. بالصورة اللي هي to the left لاحظ أنه الماس is parenchymal in the lung، والخط الأصفر يمثل لنا البلورا، والماس دافع البلورا من الداخل so it is making an acute angle with it. بينما بالصورة اللي هي to the right الماس is in the mediastinum وتحاول تدفع البلورا إلى الداخل so it is making obtuse angle with the lung. Example of mass that's causing acute angle with the lung, so it's a parenchymal lung mass. While this mass is seen in the right cardiophrenic angle, this mass is first have long area of contact with the mediastinum, second is making obtuse angle with the pleura, so it is a mediastinal mass. After making sure that we are dealing with the mediastinal mass, we will try to locate it. Take lateral chest X-ray to have better imaginations about the site of the lesion. Why we are locating the mass to certain mediastinal regions? Because we have a long list of differential diagnoses and want to minimize it. For anterior, middle, and posterior mediastinal lesions, we have in each part or in each area, we have mass, cyst, hernia, and vascular lesion. The mass in the anterior mediastinum are 4 T's. This is a summary of thymus, teratoma, اللي هي germ cell tumor, thyroid, and terrible lymphoma. The masses in the middle mediastinum, usually lymph nodes and lymphoma, as well bronchogenic tumors and lipoma. The masses in the posterior mediastinum are mostly neurogenic tumor. You have also a soft tissue mass of vertebral infections or neoplasm, lymphoma, extramedullary hematopoiesis, which is a presence into the cases of the chronic anemia. Cysts in the anterior mediastinum are thymic and pericardial cysts, while in the middle mediastinums are bronchogenic and pleuropericardial cysts, and finally in the posterior mediastinum we have foregut duplication cyst, which is related to the esophagus, and neuroenteric cysts. Hernia in the anterior mediastinum is usually Morgagni hernia, which is seen usually to the right and anteriorly. In the middle mediastinum, the hiatus hernia, which is related to the esophagus, and into the posterior mediastinum, also hiatus hernia, which is related to the esophagus, and pogdalic hernia, which is seen in the pediatric and usually to the left side. Vascular lesions is the aneurysm of ascending aorta in the anterior mediastinum, arch of aorta in the middle mediastinum, and descending aorta in the posterior mediastinum. Anterior mediastinum. Anterior mediastinum is the space anterior to great vessels and heart, and it's located behind the sternum. Signs of anterior mediastinal mass in chest X-ray is obliterations of the cardiophrenic angle, obliterations of retrosternal space in the lateral chest X-ray, and hilum overlay sign. This is an example of the chest X-ray showing hilum overlay sign, and into the CT scan, here we have axial section CT scan showing an anterior mediastinal mass. Chest X-rays showing obliterations of right cardiophrenic angle. This is a mediastinal lesion. Anterior mediastinal lesions, and the positions which is anterior is confirmed by the lateral chest X-ray. Again, we should differentiate here between the mediastinal and the parenchymal lesions by, as we said, looking to the angles with the pleura and looking to the long contact and to the other signs, as here we have right cardiophrenic angle mass. Differential diagnosis of mass obliterating the right cardiophrenic angle include the fat pad, which is very famous, especially in obese patient, pericardial cyst, and finally Morgagni hernia. And these are, as we mentioned before, the anterior mediastinal lesions. Middle mediastinum contains heart and great vessels, esophagus, trachea, lymph nodes, and nerves. Chest X-ray abnormality in paratracheal area, AP window mass, zygoesophageal recess, retrocardiac area, and it may be difficult to see on the lateral chest X-ray. These are the lines: paratracheal line, paraspinal line, right paraspinal line, zygoesophageal line, AP window, and para-aortic line. This chest X-ray is showing an example of the middle mediastinal mass. If you concentrate on the right paratracheal area, you will see multiple lobulated opacity. This is due mainly to the right paratracheal lymph nodes. In this chest X-ray, we can see in the PHS X-ray, which is number 1, there is an area of bulging into the AP window, and this is also due to the middle mediastinal lesion. These are the differential diagnosis of middle mediastinal lesions. Posterior mediastinum, paraspinal area, mass is usually visible on the lateral film overlying the spine, may obscure descending aortic contour mass. These are the differential diagnosis for the posterior mediastinal lesions. Are you able to characterize the lesion by determining whether it has fatty, fluid, or vascular component? As we said, this is usually possible CT scan. In many hospitals, a CT will be made to further analyze and characterize anterior and middle mediastinal masses. An MRI is usually made to analyze masses located in the posterior compartment because the majority of these masses turn out to be neurogenic in nature. An additional CT scan can be performed when bone needs to be assessed. So, as we can see, the mediastinal mass usually needs further assessment either by CT scan or MRI. This CT scan, axial CT scan section at the mediastinal window, showing that both the ascending and descending aorta are enlarged and there is a membrane inside. This is an aneurysm of the ascending and descending aorta. Another axial CT scan section showing multiple rounded opacity in the mediastinum anterior to the aortic arch as well posterior to it, and this is caused by the mediastinal lymphadenopathy مثل ما نلاحظ بالأسهم اللي تأشر على enlarged lymph nodes. anterior mediastinal masses في هذه الصور، كل واحدة من هذه الماسز لها خاصية تختلف عن الأخرى. مثلا رقم 1 thymic hyperplasia هي anterior mediastinal mass of homogeneous density teratocarcinoma in the other film. The third is the thymoma, also from the anterior mediastinum. The teratoma film showing fatty density inside. The lymphoma is a homogeneous mass with the blood vessels floating inside. And finally, the hemorrhage into the anterior mediastinum can be diagnosed by measuring the density and also by comparing it with the history of, for example, trauma or surgery or whatever. Some cross sections through the mediastinum showing the normal anatomy. At section A, we can note the presence of the sternum. Behind the sternum, we have the right and left right brachiocephalic vein, left brachiocephalic veins. We have the right brachiocephalic artery, left common carotid artery, and left subclavian arteries. This air-containing structure is the trachea, and this one is the esophagus, and posteriorly we have the spine. If we are ascending upward a little, we will see the aortic arch, and here we have the trachea and the esophagus. This is the superior vena cava, and it appears white because it's injected with the contrast. Lower sections, lower to the aortic arch, we can see this ascending aorta, descending aorta, pulmonary trunk, the right main pulmonary artery, and we have the superior vena cava and hilar vessels. Also we have the right main bronchus and the left main bronchus can be seen. This is the esophagus. At lower sections we will have the right ventricular outflow, aortic root, sternum, and we have the left atrium, right lower lobe vessels and the bronchi. We will also have the esophagus and the descending aorta. Examples of mediastinal lesions. This PA chest X-ray is showing air fluid containing opacity behind the heart. In the lateral chest X-ray, it seems to be located into the middle mediastinum. It's found to be hiatus hernia. This chest X-ray, or both of them, showing widening of the superior mediastinum. The widening is lobulated and the trachea is seen to be compressed. The cause is retrosternal goiter. These chest X-rays are chest X-rays of pediatric age group, and we have widening of superior mediastinum, and here because of the presence of the normal thymus. The normal thymus may be lobulated, smooth, or may make what we call it cell sign. Hilar enlargement. Hilar enlargement could be bilateral, unilateral, or neoplastic. A normal hilum should be concave, never convex. Whenever the hilum is convex or bulky, means that there is a hilar enlargement. The hilar enlargement could be bilateral or unilateral. Bilateral enlargement seen in the case of lymphadenopathy, وهنشوفها عادة بالساركويدوسيس or lymphoma or some TB or fungal diseases. The unilateral hilar enlargement may be metastasis from the bronchogenic carcinoma, maybe lymphoma, maybe infection. But unilateral speculated hilar enlargement is highly suggestive of the carcinoma. So the third is called as a neoplastic, اللي هي bronchogenic carcinoma plus minus lobar collapse or consolidations. This is named with a special sign called as golden S sign. تكلمنا عنه بالمحاضرات السابقة وأيضا في العملي. These chest X-ray showing bilateral lymphadenopathy versus unilateral lymphadenopathy, and you can notice that the hilum is bulky and dilated. Elevations of the hemidiaphragm. طبعا evaluation of the diaphragm is very important part of the chest X-ray. Not only the lungs, the mediastinum and the pleura, but also the diaphragm. The diaphragm elevations, normal diaphragm, as we said in the introduction, أنه right diaphragm is higher than the left diaphragm by 2 centimeters or less. Just in minority of people, normal people, the right and left dome of the diaphragm are at the same level. Elevations of the diaphragm, whether right or left, may be due to the causes in the chest that's pulling the diaphragm, like the pulmonary collapse, or causes in the abdomen that's pushing the diaphragm upward, like the subdiaphragmatic abscess or abdominal mass. The elevations of the diaphragm may be incidental finding, just as in, for example, diaphragmatic hump or ventration. Or it may be due to the paralysis, like phrenic nerve palsy. This is seen usually in cases of a bronchogenic carcinoma with the invasions of the phrenic nerve, so that the diaphragms move up with inspiration. This chest X-ray showing localized eventration of the right dome of the diaphragm. Chest wall is very important part of evaluations in the chest X-ray. We shouldn't forget to evaluate soft tissue as well rib abnormality. Soft tissue swelling may occur from rib lesions, for example, fracture, infection, tumor, Rib abnormality occur in cases, for example, Paget's disease, myeloma, secondaries, invasions from underlying carcinoma, rib notching. Congenital rib anomalies are common, for example, bifid and fixed rib. In this chest x-ray, we can notice that the right lungs, especially the lower zone of the right lung, looking more radiolucent than the left lung, or in the other word, the left lung lower zone looks more opaque than the right lung. In this case, the problem is not in the lung. In fact, the case is of CA breast with right side mastectomy. If you look to the breast shadow, you can see that only the left side there is breast shadow, and the breast shadow is missing from the right. That's why the right lung appears more translucent than the left. So you should keep this in mind when you are dealing with a difference in opacity between two lungs to check for the chest wall, for example, in cases of the mastectomy or in congenital absence of some muscles. This is the end of the lecture. If you have any questions, you can send it to me by Telegram or Moodle